Good morning, Chairman. We are ready to begin.
Good morning, Denisha. If you conduct the roll call, please.
Yes, Chairman. I'll begin with Roger Folsom,
Here.
Cynthia Rucker,
Here.
Tommy Hopkins,
Here.
Norman Boyd,
Here.
David Cruz,
Here.
Anthony Williamson,
Here.
Shane Mobley,
Here.
Robert Coles, Kathleen Ruth, Chairman, that concludes my roll call.
Thank you, Denisha. We have a quorum present for this call meeting, and we're appreciative to all the board members for their time this morning. The commissioner will give you some format as to why we're having this call meeting momentarily. But I know we've disrupted some tea times and probably delayed some early Friday departures for a long weekend maybe. And with some of you, we appreciate your time and commitment to this. It's very important. I know that there has been a lot of coordination between governor's office, the department, and all the entities involved. And the issues we have before us this morning are very important, as the commissioner will highlight. And with that, we'll move on into our session and get this done where you can get your Friday underway, everyone. Commissioner Carlson, please.
Yes, sir, Mr. Chairman. Good morning to you, Mr. Chairman, members of the board, and those of you joining virtually today. On behalf of the entire DCH team, I want to first thank our board members for joining us today on such short notice. Please know we do not take these special meetings, these called meetings lightly, and would not ask for your time on the summer Friday morning if, as the chairman said, we didn't feel these matters warranted immediate attention, important matters before us. Additionally, I want to thank Denisha Williams and the other DCH team members for helping us pull this together. Our guys behind the curtain back there and our many team members. These things don't just magically happen. So what has us here today? To get right to it, we're doing our best to be responsive to the Medicaid conversations in Washington. We've referenced this in previous board meetings and have done our best to have a consistent message. We want to monitor the debates in DC as closely as we can, and if need be, make the best, most educated decisions we can on how to react to the policy debates on the Hill. Not overreacting in this 24/7 news cycle, but gathering the best information we can, reading the political environment the best we can, and acting responsibly. Of all the Medicaid discussions happening in Washington, one of the policy decisions that could potentially, depending on how it ultimately lands, impact Georgians the most is the discussion surrounding directed payment programs, or DPP. And this is what is on the agenda before you today. We utilize DPPs in the state now, and we utilize them in our minds well, responsibly, tying them to GME, medical education, quality workforce investment, and sending a great deal of needed funding to strengthen our rural hospital network. But there's a healthy DPP debate afoot in DC now, and we want to do our best to position Georgia and how we manage this hospital funding mechanism in a manner that will ultimately gain approval in the current environment. This is for initial adoption. As for our initial proposal, please know that the debate in DC continues and changes could impact this proposal, but also B, just a reminder that this is the first step and not the last. CMS will take time to review proposals across all states and evaluate these proposals in light of whatever the law of the land ultimately is. And proposals before CMS often take the form of a conversation or a negotiation, as opposed to a binary up or down vote. So again, this is the first step and not the last. So at this time, I'd ask Joe Hood, our COO, to step up and explain. Well, you're already up, Joe. So to go ahead and explain what's before us today and a little bit of how we got here and a little context about the programs themselves. So thank you, Joe, for all your hard work, and Cody Whitlock here and Lynette Rhodes and several others that have been a part of this conversation here in the last few days. Thank you, Joe.
Well, thank you, Commissioner. Good morning, Mr. Chairman, Commissioner, and board members. Thank you for your participation today at our board meeting. My name, as Commissioner stated, is Joe Hood, and I'm the Chief Operating Officer for the Georgia Department of Community Health. We have 3 items for consideration of initial adoption by the board today. Each of the action items are in support of programs that support the department's overall strategy to improve healthcare services to Georgians, including these 3 items: to advance the state's quality strategy with targeted improvements in maternal, pediatric, behavioral health, and chronic disease management, to preserve and expand the state's healthcare workforce, and lastly, to improve access to care by supporting and strengthening Georgia's state safety net rural and teaching hospitals. First, before we get to the items on the agenda that are considered for initial adoption, I would like to provide an overview of direct payments and then explain how the action items support the state's quality healthcare strategy. The department has implemented hospital direct payment preprints, supplemental payments over past years with approval from the board and from CMS. A directed payment is an additional payment made to hospitals providers by the care management organizations or CMOs to compensate and incentivize those providers to achieve additional state-directed quality and improvement measures, in addition to payments providers receive for the direct patient care they provide to Medicaid members. The initial payment for providers is received from their negotiation with their CMO contract. The supplemental payment is separate and apart and is 100% pass-through from Medicaid at the department to the providers and does not provide any additional payment to the CMO. This allows the Department of Community Health and the state to set priorities in quality workforce investments and other key healthcare improvement areas for providers to work towards achieving goals and objectives above and beyond providing the frontline patient care that is separate and apart from what's negotiated in their CMO contract. In Georgia, the payment is divided into 2 categories of hospitals to make the state matching component that's required by the federal government. There's public hospitals and private hospitals. For the public hospitals, those are owned by county governmental hospital authorities, and they are able to provide a hospital provider state match in the form of an intergovernmental transfer, known as an IGT. The public hospital provider transfers to the state, the Department of Community Health, the matching portion of the supplemental payment for the payment program at the time of payment in the exact amount that is required for their hospital. And the department then draws the associated federal portion, or the Federal Medical Assistance Percentage, known as FMAP, and returns the combined payments from the hospital and the federal draw at an individual level to each CMO for the payment to each individual hospital, depending upon the CMO claims that each has. That was the determination for the matching percentage. However, when we turn to private hospitals, the match component is different. Whether it's a nonprofit or a for-profit private hospital, the state matching fund for a directed payment is provided by an assessment that each individual hospital is identified in the DPP and approved by CMS. For these private entities, they are prohibited from making a one-to-one hospital-level intergovernmental transfer like public hospitals provide by federal regulation. Therefore, the state has authorized a hospital provider tax to make this match as a private hospital assessment. Basically, private hospitals are assessed similarly regardless of the amount of the payments that may receive from the program that's being approved. and it's not at an individual level as is in the previous described public hospitals. The tax is meant to be separate and apart from the supplemental incentive payment and the payment solely based on Medicaid claims utilization. Today, we are presenting to you adjustments to two of our existing direct payment programs. The first payment program is the Hospital Directed Payment Program known as HDPP, Hospital Directed Payment Program. This supplements the Medicaid initial CMO claims with an additional amount of payment up to the Medicare rate plus 10%. This program is the base program for most participating hospitals, but currently excludes freestanding children's hospitals. This proposal today would amend the Hospital Direct Payment Program definition to now include the only two freestanding children's hospitals in Georgia to allow them to receive the supplemental payments for further quality and staffing objectives. The second hospital-directed payment preprint program that is impacted as a part of today's actions is STRONG, which has a state goal of improving Georgia's healthcare workforce and currently expects participants to reinvest up to 20% of program revenue into workforce initiatives such as recruiting, training, and retention. This supplemental payment program has a specific focus on expanding staffing for healthcare throughout Georgia by promoting and supporting teaching hospitals with graduate medical education programs. There is a significant cost in staff and infrastructure required for a teaching hospital to have an ongoing GME program. This supplemental payment encourages hospitals to expand and maintain GME programs in all specialties. It builds upon the hospital-directed payment program and pays an additional payment after the hospital-directed payment program is complete. The new total payment, when combined for hospital-directed payment preprint and STRONG preprint for teaching hospitals, can reach up to 200% for hospitals with 5 or more GME participants annually in their program. It also has a lesser payment for hospitals which have not yet achieved 5 or more GMEs who have in a cost report for that particular year utilized for the program. In both HDPP and STRONG supplemental payment programs, the private hospital assessment is determined by totaling the estimated federal payment for both of these programs for all defined hospitals to determine the total state match. At this point, a calculation is made to assess each of the private hospitals for the match on the basis of their net inpatient revenue. The assessments are then collected, and then the individual hospital payments are determined by medical claims of each CMO as described previously. Throughout last fall and winter, DCH sought feedback and input from providers on recommendations to further enhance Georgia's direct payment preprint programs. The current federal landscape offers a limited opportunity, as the Commissioner referenced, to advance these programs. DCH is presenting an additional program tier to allow flexibility to achieve even further investment in Georgia's healthcare system. This additional direct payment program is titled Georgia Strong for Healthcare Improvement, or Georgia HIP for short. It would add one last supplemental tier of payments for eligible hospitals in both our existing HDPP program and STRONG programs. It would add a payment above each of the existing payment levels up to a statewide commercial average rate. To be clear, this is an addition and on top of the two existing programs. It does not change those programs as they reside today. For eligible hospitals in each of the HDPP and STRONG, it would add a payment from the last highest percentage of Medicare up to the state average commercial rate, or ACR, for the cost period approved. In order to ensure quality and reinvestment directly into the healthcare system, these programs would be designed with two sets of quality metrics. The first would be state-directed conditions of participation, which are separate and apart from the CMO contract, where the state, working with the providers, would develop a roadmap to a strong healthcare system and require the providers to invest significant funding from this revenue in these programs, such as creating new graduate medical education slots, achieving higher retention rates of Georgia-trained physicians, and expanding OBGYN services throughout the state. In addition to the conditions of participation, each of the hospitals will have 10% of the payment not provided unless certain quality improvement targets are met by each hospital, placing 10% of their payment at risk. The Georgia HIP DPP is designed with a private assessment task structure that aligns with provider services by assessing hospitals utilizing non-Medicare bed days to establish the percentage each private hospital contributes to the assessment. Due to the nuance, the department must seek a waiver of non-uniform assessment from CMS to get approval. Therefore, there is an additional item on the agenda for this waiver consideration. Before proceeding to each item for a vote consideration that we have on the agenda for initial adoption, I'd like to pause here for any questions.
All right,
Any questions?
all
Go
right,
ahead.
question. When on the Board of Regents, I was in charge of establishing the GME initiative throughout the state, and it's very, very complicated. And I just wonder where the input for increase in GME came from. Is that from the legislature, or is it, or somebody just? I'm not sure where it comes from because it's a very complicated subject. So can you kind of expand on that, please?
Yes, sir. Previously, when we had our strong directed payment preprint program that is pre-existing and we've had it in place, we had discussions with teaching hospitals and with all of the stakeholders of the party. And throughout the summer, we had also had discussions with associations and, in fact, many discussions with the Board of Regents themselves to further GME, but to build upon the 5 GME status that we had in this existing preprint. And as you may be aware, there were additional appropriations items that were approved in our administratively attached agencies to our budget to further that and fund slots. This really seeks to give hospitals the opportunity to further GME programs, to add additional programs that they may not have, or to further slots in existing teaching hospitals. It may go towards some smaller hospitals that wish to build a GME program to have infrastructure and or staffing that would create or expand some what we would call growing GME programs that are less than 5. But that's generally it. There was a lot of thought and discussion throughout the year building up to the point to form that we need to try and further GME in the future.
Because, you know, there's a federal law that you cannot expand an existing GME program. They all need to be de novo to grow unless something's changed in the last 2 or 3 years. Because, you know, we looked at trying to expand programs at MCG, at Emory, and other existing programs, but they would not let us expand on an existing program. They had to be new programs. So we just need to keep an eye on that because it gets very complicated, and we've got some expertise in the system that can certainly advise us.
Yes, sir. And we certainly rely upon our administratively attached agency for workforce and the hospital associations and the Georgia Board of Regents to assist us in those matters, and will continue to do so.
Thank you.
Any additional questions for Joe? Any board members? Joe, I know you covered a lot of geography there in that summary, and I appreciate your doing so. I know these issues tend to get heavy, and we can get out into the forest very deep, particularly for board members that are not involved in hospital situations day to day. But that was an excellent summary. Before we begin the agenda, are there any additional questions for Joe? Okay, hearing none, we will begin with the first item. All items we're considering this morning, as the commissioner reported, are for initial adoption, all 3 of these items. So The first one is Georgia Strong for Healthcare Improvement Directed Payment Preprint. Joe?
Thank you, Mr. Chairman. The first item, as you referenced, is the amendment of the previously implemented hospital-directed payment program. This amendment simply adds 2 freestanding children's hospitals to the eligibility of the supplemental program. For informational purposes, upon CMS consideration and input, the department will need to make an additional administrative rule change to the non-governmental hospital definition of the provider tax at a future meeting to finalize the addition of the children's hospitals. I wanted to explain that a little bit further. We want to first submit this to CMS and have all consideration, as the commissioner referenced, with their questions and answers, and make certain we know exactly what would need to go into that administrative rule change. And then we would bring that back to the board for consideration and go through our normal process for that. But I felt it important for this vote to make certain that you are aware they're in tandem. We have to do the administrative rule change, and that's what we're assuring CMS we will be doing with this proposal as we submit it. With that explanation, Mr. Chairman, if there are no further questions, I would ask for favorable consideration of this DPP, which has a total estimated payment for the program of an estimated $527,965,306, as noted in the public notice. Please note an opportunity for public comment will be held on July 2nd, 2025 at 10:30 a.m. via Zoom audio, and written comments will be accepted for consideration by the department from individuals on or before July 9th of 2025. That concludes my presentation, Mr. Chairman. I'd ask for favorable consideration for initial adoption.
Thank you, Joe. Are there additional questions for Joe before we consider a motion? Hearing none, would there be a motion for initial adoption?
Shane Mobley, motions.
Shane Mobley has moved for initial adoption. Is there a second?
Second, Dr. Rucker.
Cynthia Rucker has seconded the motion. Any further discussion? Hearing none, all those in favor signify by aye.
Right.
Aye.
Any opposed, no. Anyone abstaining? For the record, the motion carries unanimously. Joe, we'll proceed to the second item, which is changes to hospital-directed payment preprint, addition of freestanding pediatric hospitals.
Okay, Mr. Chairman, that's the one that we just voted on. I may have taken, I may.
Yeah, I think
I
we
thought that I may be out of order, so I apologize. So this one is going to be the adoption of additional supplemental payment programs for the additional tier of payments to achieve at-risk and mandatory participation objectives.
Let me interrupt you just a minute,
Yes,
Joe.
sir. Yes, sir.
For board members, we're going back to item D. We just approved with those motions item E on the agenda, but now we're going back to item D, so everyone's clear on what we're doing. Thank you. Go ahead, Joe.
Thank you, Mr. Chairman. I apologize that my notes are out of order evidently on that note. This item is the adoption of a new directed payment preprint, as previously referenced, titled Georgia HIP. It's the addition of supplemental payment program to add an additional tier of payment to achieve at-risk and mandatory participation objectives of the participating hospitals as previously described in HDPP and Strong into this new program, Georgia HIP, for the last tier. This supplemental payment is in addition and complementary to those two programs. Georgia now has in place to add payments up to the state average commercial rate for eligible hospitals. So essentially, we're going from whatever place and point a percentage that they were at, either in hospital-directed payment preprint or Strong, to the average commercial rate for all eligible hospitals. The total estimated funds that would be added from Georgia HIP are $3.2 billion. There will be an opportunity for public comment on the proposal on July 1st, 2025 at 11 a.m. via Zoom audio. Written comments to the department for consideration by individuals will be accepted on or before July 8th, 2025. If there are no questions, I would ask for your favorable consideration for initial adoption of the Georgia HIP program.
Any questions for Joe? Hearing none, we'll entertain a motion for initial adoption.
Shane Mobley motions.
Shane Mobley has made a motion for initial adoption. Is there a second?
Second.
David Cruz.
David Cruz has seconded the motion. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
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 Anyone opposed, no. Would there be anyone abstaining? Hearing none, the motion carries unanimously. We'll move to the third item, which is the medical assistant plan's waiver of uniform tax requirement.
Thank you, Mr. Chairman. As previously referenced, this last item is a waiver of non-uniform assessment. It is the mechanism or methodology that will be used for private hospital assessment in Georgia HIP. As I mentioned earlier, Georgia HIP seeks to align private assessment to best match the quality and staffing outcomes to hospitals utilizing non-Medicare bed days. This does not meet the uniform definition by CMS for assessment and requires a waiver. However, given the nature of the last payment the department needs to match the assessment closely to the outcomes of bed days where maternal, pediatric, and chronic disease are most utilized for Medicaid, meaning at $3.2 billion, we want to be sure that we're aligning the outcomes of what we're trying to achieve with the assessment as closely as we can. There will be an opportunity for public comment on the proposal on July 2nd, 2025 at 11:30 via Zoom audio. Written comments to the department for consideration by individuals will be accepted on or before July 9th, 2025. If there are no further questions, Mr. Chairman, I would ask for favorable consideration for initial adoption.
Any further questions for Joe? Hearing none, we'll entertain a motion for initial adoption.
Tommy, so moved.
Tommy Hopkins has made a motion for approval. Is there a second?
Second, Dr. Rucker.
Cynthia Rucker has seconded the motion. Any further discussion? Hearing none, all those in favor of the motion signify by aye.
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 All opposed, no. Anyone abstaining? For the record, the motion appears to pass unanimously. Anything further, Joe? Those are the three items.
No, Mr. Chairman, we appreciate it.
I was a
Thank
dump
you
truck
today.
load this morning.
Thank you so much.
Thank you. Any new business or any further comments from any of the board members or Commissioner Carlson?
This is Shane Mobley. I want to thank Joe and all the excellent work the department has done on this matter. And Joe, as usual, always does a great job. And we really do appreciate everything you do. Thank you so much.
Thank you.
That's a good remark, Shane. There's been a lot of work in the background, and I was going to end with accolades to the commissioner and Joe and the entire department. There've been a lot of scrambling, a lot of listening, a lot of input received, and coordinating with the governor's office in Washington and all the entities involved. A lot of moving parts in this thing, and thank you to the board for coming together on short notice and conducting this business this morning. If there's no further new business or anything else, we will stand adjourned and let you get started with your weekend. Thank you, everyone. Have a good
Thank
Thank you,
you.
Mr. Chairman.
Thank you.
Thank you.